transplantation is associated with the dosage of immunosuppressive agents given the environmental factors and the post-transplant duration. Usually, bone involvement classically has been considered exceedingly rare for both immunocompromised and immunocompetent hosts. However, there are limited data in transplant recipients. So with this brief introduction, we'll go ahead with the case history. So my patient who came to NIMS was a 60-year-old gentleman who was a farmer by occupation, who was a resident of Sangareddy district of Telangana, and who was a known case of CKD. The native kidney disease was not known, and the patient was in a dialysis for a dialysis vintage of 5 years, and he was undergoing 3/7 dialysis, weekly thrice dialysis at Sangareddy district. He did not have any other comorbidities, and his past histories include a peptic ulcer disease for which he underwent a surgery. Exact details were not known, and he had a history of COVID-19 pneumonia 10 months back prior to the transplant surgery. This patient, he initially presented to an outside hospital where he underwent renal transplant surgery. So the donor who gave the donor was 67-year-old female whose cause of death was renal tubular acidosis with no comorbidities and the creatinine of 0.88 milligram per deciliter. Since the patient underwent renal transplant outside our institute, we did not get the details of the KDPA score. And after a negative cross match by negative lymphocyte cross match, the patient underwent a renal transplant surgery on 30th of November 2021. And the cold ischemia time was 12 hours, and the patient received an induction ATG of 100 mg over a period of 2 days. So the first setback, immediately post-surgery, the patient had decreased urine output, and there was no improvement in renal output even after transplantation on day 1. So the patient demanded 1 session of hemodialysis. So as a good thing, the second day, the patient had gradual improvement of renal function, and gradually the patient was off dialysis. And by day 5, his creatinine reduced to 1.9 milligram per deciliter. Later on, from day 6, the patient unexpectedly had a asymptomatic rise in creatinine from 1.9 to 3.5 milligram per deciliter on day 7 over a period of 2 days. So in view of this asymptomatic rise in creatinine, he underwent a renal biopsy, which showed mild segmental glomerulitis with mild interstitial inflammation and acute tubular injury, mild peritubular capillaritis with occasional neutrophils, endarteritis, and focal C4D positive, all indicating an ABMR. So the patient was treated with 5 sessions of plasmapheresis and IVIG. The exact dose of IVIG is not known as the patient details were not available. And the patient was discharged with a creatinine of 1.7 milligram per deciliter. So the patient was continuing treatment at a outside hospital. So he was doing well for the next 3 months. So then came the first catastrophic incident in February 2022, where he presented to the same hospital with history of fever, breathlessness, and with severe allograft dysfunction. So the patient was diagnosed with urosepsis, CMV pneumonia, and anemia. With whatever data was available, it was known that the patient was stopped on all immunosuppressions, and the patient was treated with IV valganciclovir and broad spectrum antibiotics. After stopping immunosuppressions, the patient also had a progressive decline in allograft function, so he was reinitiated on hemodialysis. So after some few sessions of hemodialysis, he came to our institute. So he showed off to NIMS in March month of 2022. So when he came to NIMS, he had a femoral line in situ, and he did not have any fever. He was hemodynamically stable. We admitted the patient and we investigated him. He was found to have CMV PCR negative. His blood culture, urine cultures were sterile. So the patient was not showing any active focus of infections. So to declare whether the patient has gone into graft loss or not, we had to undergo a renal biopsy. And surprisingly, the renal biopsy showed 1 out of 8 glomeruli were sclerosed and other glomeruli were normal, with exfoliation and simplification of the lining epithelium. There was only mild interstitial inflammation with lymphocytes, however, no evidence of lymphocytic tubulitis. So the features were all suggestive of just an ATN. Since the patient did not have any other source of infection, we reintroduced the patient on tacrolimus and MMF. So finally, the patient had showed a had got a ray of hope that he may further continue with his graft function and he may be off dialysis. In the same way, the patient had been observed maintained off dialysis, and his urine output gradually improved, and his discharge creatinine was 2.95 milligram per deciliter, and he was off dialysis after visiting our institute. And the curse in disguise. So next he came to OPD after a period of 15 days, during when his creatinine was still maintaining at 1.57 milligram per deciliter, and he was having a very good urine output, and the patient complained of some mild vague pain in his right foot. Since the patient did not have any local swelling, warmth or tenderness, the patient was prescribed paracetamol and asked to review after 3 days. But the patient came after 7 days with significant pain and swelling of the right foot. So here starts the history of pertaining to the presentation. So the patient underwent various investigations, and the significant where he had a high leukocytosis with a neutrophilic predominance, and his graft, he had a mild graft dysfunction from 1.57, his creatinine increased to 2.42 milligram per deciliter, and other investigations were within normal limits, and his TAC level was 12.7 nanogram per deciliter. So since the patient had a significant swelling of the right foot, swelling and tenderness of the right foot, he underwent an X-ray which showed significant destruction of the tarsal bones with significant edema. You can see here that the tarsal bones and the base of the metatarsals has been eroded in this X-ray. So we went ahead with the HRUS. In the HRUS, it showed a thick collection which is extending into the intermuscular space. And we also did an MRI of the ankle joint, which showed osteomyelitis with bony destruction of navicular, cuneiform, cuboid and base of metatarsals. We can see here there is echogenic collection, thick echogenic collection in the metatarsal and the base of on the navicular bones, cuneiform bones, and also the base of metatarsal, and it also extend into the lower leg also. So here also you can see there is patient of liquefaction and patient having thickened echogenic collections in these two sections also. So since the patient had some echogenic collection, we went ahead with aspiration, fine needle aspiration cytology of the collection. And the smear showed highly cellular slide with plenty of neutrophils with degenerated cells, macrophages, cellular debris against necrotic background. And the numerous brown septate hyphae were seen. So here you can appreciate the septations, and these are all the neutrophilic background, and here we can appreciate the hyphae, numerous septate hyphae. So to enhance this septate hyphae, we had to stain the slide with a SM stain, which is particular for septate hyphae. And here you can see the branching septate hyphae with a bullous expansion also. So all these were suggestive of a phaehyphomycosis, which is caused by a demetaceous fungi. So why they call this as a demetaceous fungi is these are melanin producing fungi. So these will produce a brown color staining because of the melanin, and they are called demetaceous fungi. So next, since we had a clue that it was a fungal infection, the patient underwent, we initiated the patient with IV antifungals with voriconazole initially, and the patient was given a slab rest with IV tramadol also based on the orthopedician's advice. But after 1 week of treatment also, the patient did not show any signs of improvement. And he was gradually, his sepsis was, patient had a significant swelling, and the swelling also extended to the mid leg also. So later on, we had a orthopedics reconsultation. Since the patient had persistent swelling and no improvement with IV antifungals, the patient had advised for below knee amputation of the leg. So here you can see there is a, so here you can see this was the incision where the patient was taken for OT, and this was the incision. After the incision, you can see the pus oozing out from the skin. So the patient was having a severe tenderness and warmth, and with almost bullous eruptions over the skin. So with a single nick, there was pus oozing from the wound. So the patient, we went ahead with the amputation of the leg, and with the aspirated fungal aspirated elements, the KOH preparation was done, which showed plenty of branching septate hyphae, and the calcifluor white mount also showed up plenty of branching septate hyphae. And this was the culture report after 2 weeks, which was showing a hyphae with sickle-shaped macroconidia, which are typical of fusarium. So by this, we had confirmed the diagnosis of fusarium, species of fungi. So this was the amputation picture. The patient, this was after amputation, the patient gradually over a period of 2 weeks, the wound healed like this, but still there was a dry gangrene, and this gangrenous was showing some oozing also. So again, a re-exploration was done, and this shows, especially after a debridement, there was a fresh granulation tissue. The patient was continued on IV antifungals, and as soon as we got the culture of fusarium and the patient was gradually progressive declining in clinical condition, we had to start on amphotericin also with IV voriconazole. So after an IV antifungal dosage of voriconazole was given as 4 mg per kg IV in 2 divided doses, and amphotericin at 3 mg per kg, liposomal amphotericin at 3 mg per kg. Liposomal amphotericin was continued up to 6 weeks, and voriconazole was continued up to 8 weeks. And underlying immunosuppression was stopped once the patient condition started declining. Once the patient, and the immunosuppression also was minimized to the lowest possible dose of TAC 0.5 mg BD and the prednisolone of 5 mg OD. So he improved significantly after the amputation, and with 8 weeks of IV antifungal, the patient had achieved a creatinine of 1.8 milligram per deciliter with a very good urine output of nearly 4 liters per day. So finally, after 3 months, he is on regular follow-up with us, and even he came in September before 2 weeks, during which his investigation showed his hemoglobin of 11 gram per deciliter, total count was normal, platelet count was normal, his creatinine was doing good at 1.89 milligram per deciliter, and the patient gradually over a period of 1 or 2 weeks, once the patient clinical condition and the wound was healthy, we reinitiated him on mycophenolate mofetil with 250 mg once daily and tacrolimus of 0.5 mg twice daily. And routine TAC levels were also monitored, which was 5.5 nanogram. So this was my case presentation. To have a brief discussion, so this invasive fungal infections are a major problem, particularly in solid organ transplant recipients. Overall, the most common fungal infection in solid organ transplants are candidiasis, followed by aspergillosis and cryptococcus. And which we have seen, which was fusarium, and the patient, the risk factors associated with this patient, which had made him susceptible for this debilitating invasive fungal infection, was his old age, and he was not associated with diabetes mellitus, and he had a previous history of CMV infection. He had a allograft dysfunction, and he had a treatment of rejection also with IVIG and plasmapheresis. So all these were the predisposing factors for him to get this invasive fungal infection. So what is this fusarium? Fusarium species are ubiquitous molds that thrive in soil and decomposing vegetations. Usually they affect solid organ transplant recipients, but still it is an uncommon event. And fusarium species cause a broad spectrum of infections, including superficial, such as keratitis and onychomycosis, locally invasive, or a disseminated infection, which is exclusively seen in severely immunocompromised patients, like HIV and post-transplant patients. So disseminated infection is seen in 70% of fusarium species. And so this disseminated infection is mostly restricted to patients with severe immunosuppression. Even though the presentation is disseminated disease, it is comparatively rare. And this fusarium has been very commonly documented compared to other solid organ transplantations. It was very commonly seen in patients with acute leukemia and then patients who underwent a hematopoietic stem cell transplantation. So once we diagnose the patient to have a fusarium, we had various studies where the patient was treated with amphotericin and voriconazole. So this, based on this clinical microbiological review article in 2007, based on this, amphotericin is the most susceptible. Susceptibility is better to fusarium species compared to any Candida or Aspergillus. So amphotericin B remains the first choice of antifungal in fusarium species, and azoles, though they are fungicidal, preferably voriconazole can be used, but their efficiency is less compared to amphotericin B. And voriconazole has been documented very well to have treated in treatment of fusarium patients, and other antifungals that can be used are posaconazole, itraconazole, and isavuconazole, but the data available are significantly less. So echinocandins, they don't have any role against fusarium species. So the key in this was the early diagnosis of fusarium species, because we commonly suspect a Candida infection where the patient will be very susceptible to echinocandins, but this fusarium species does not have any activity to echinocandins. So finally, coming to the conclusion, so the main important thing to note is the balance of immunosuppression between the risk of rejection and the risk of infection. So immunosuppression requires a age adoption protocol that goes beyond the current clinical practice of as how much as necessary and as little as possible. So based on the age, we have to definitely have a separate protocol for transplant patients. And all post-transplant recipient with even vague symptoms should be investigated thoroughly and aggressively treated. So invasive fungal infection should always be in the differential diagnosis of all post-transplant infections. Thank you once again for giving me this opportunity to present.
Thank you, Dr. Prasanna, for that enlightening case discussion. So it was quite alarming to note that a person actually lost a limb within a week span. So, but that's how things are in transplant. I would like to now invite the chairpersons for their comments.
Yeah, good evening. So this was a very interesting case. We had very difficulty in treating the patient and taking a call on whether to go ahead with the immunosuppression, because already he had rejection. He was treated, and then he was declared actually half loss, and he was put back on the hemodialysis. So though initially we could successfully salvage the graft, subsequently when he again came with an infection, but particularly disseminated fungal infection. We were skeptical, and in fact, he was very malnourished, and at one stage we thought we will lose the patient. That's why we decided to go for an amputation. And we have actually, for a few days, we have started immunosuppression except for the steroids. And when the patient was stabilized and then amputation was done, and still, despite that, the graph was was maintained that creatinine between 1.5 to 2. Maximum we have noticed is 2.4 only. So, fortunately, we salvaged the patient at the cost of the pandemic. And one more point, the challenge was about antifungal treatment. I mean, what to start, how long to be given. So these were the issue, and particularly when we were giving when the voriconazole, adjusting the tacrolimus, because initially, though we have stopped tacrolimus, whether we were also thinking whether to reinitiate and what to initiate, how much to do. So these were the challenges. So, so I think this was a learning lesson for us also. Immunosuppression as well as the the infection and the patient and graft. So I request expert comments from the chairpersons and then the expert in the infectious diseases, the team who are here.
I would appreciate Dr. Prasanna. He presented so well. I'm not sure if he'll do such a good job as a resident. So that was wonderful. And my question to maybe Swarnalata. So did you use IV voriconazole? Did you say IV voriconazole?
Initially IV voriconazole. Subsequently we changed to oral, because initially when we were given the report of septate fungal hyphae, we were thinking aspergillus, and we have started the IV voriconazole. We have changed to oral. Because looking at the leg, it was so when swollen, and then it was so we had given initially oral, And initially IV followed by oral. Subsequently, next week when there was no response, then we have added amphotericin.
So did you have any issues with the any liver function abnormality?
Liver
Anything?
function was absolutely normal. Throughout the course, liver function was normal.
Was a patient on dialysis when you started IV voriconazole?
No, he was never on dialysis. Like, when the second time, initially, when he presented to us, referred for a maintenance dialysis to our center. So, but we found that urine output was good. And then we wanted to do a graft biopsy before declaring, because initial biopsy showed only an active use of ABMR, active ABMR. So then we did a biopsy, and subsequently we saw that it's absolutely normal except for the mild ATN, and then there was no inflammatory changes, no tubulitis, no change in features of ABMR. So that's when we thought we can just hold a dialysis and think of salvaging the graft and then reinitiation.
We normally worry about giving IV voriconazole.
Yeah.
They are not on dialysis because of the accumulation of the carrier.
Exactly.
So I was just wondering, did you have any issues? Did you see?
No, initially we didn't. Our concern was only because it was osteomyelitis. So only for the what you call the better the concentration, better pharmacokinetics and pharmacodynamics, we gave the IV.
Okay.
I'd like to add a comment here. That's one letter. Dr. Abrami. I'm Dr. Sunita Narede. I'm one of the infectious disease physicians at Hyderabad Apollo Hospitals. So when you comment on cyclodextrin and voriconazole, it's only present in the IV formulation. That's why you were asking, I understand. Now, cyclodextrin is not removed by dialysis. So we'd be worried actually if you're using it in patients in dialysis. However, we've used IV voriconazole in a lot of patients who are on dialysis as well. So far, I have not had anyone that I've had trouble with. We always worry about giving when you have CKD, SRD. Yeah, anecdotal reports have used it and they didn't have problem, and I have not had any major problem. So IV voriconazole.
Okay.
Okay,
And,
I would like to
in terms
congratulate Dr. Prasanna for the nice presentation. And as it is said, the Congress was diagnosed very early, and that's why we could salvage the patient. But unfortunately, the limb could not be saved. But at least the patient is now living with a near normal graft function, and he should be happy for the early diagnosis. And as Dr. Prasanna pointed out, it is a lot of risk factor. One was the age, and second is the immunosuppression. That is, he was given an induction, followed by he developed an ABMR, and again IVIG and plasmapheresis was given. So that was his problem. And I have a question to Swarnalata. When he came back to NIMS, after when he was declared that he has lost his graft and he was being referred for maintenance hemodialysis, he improved because his urine output was good, and you removed him off dialysis and you restarted the immunosuppression. And probably that was again a trigger for infection.
Yeah, in fact, retrospectively, when we were trying to analyze the whole scenario, so what we have now realized is by the time of discharge, when we have reinitiated immunosuppression discharge, he was actually complaining of mild pain, which we overlooked. And then within 1 week, he came back. So probably there was some, the source there.
Lingering infection.
Yeah, infection, which we have missed initially. So retrospective, we were thinking he was just casually was complaining, but there's some, pain in the right foot.
So generally, we think of uric acid being high, causing these problems in post-transplant scenario. We never suspect a fungal osteomyelitis.
The osteomyelitis was, in fact, a surprise for us also. In fact, we were trying to talk to orthopedician and somehow salvaging the limb. So they said it's very extensive, it's difficult. Before you take a call, before we go into aboni amputation. So that was their version. So we thought below is better than the aboni amputation before it spreads to the entire.
That was a right decision, I think.
Yeah. I would agree with that, and a very good case. Did this guy was a farmer? Did he go back to farming by this time?
No,
or was he still at home?
Because it happened before. I mean, I don't know before presented to our hospital whether he got back to his work, but after he came to our hospital, because it happened, so rapidly, so he never, I mean, went back to his
Before that initial hospitalization, because
My-
fusarium is a soil bug,
Yeah,
and
exactly.
his
Farmer is one of the
source
risk
of
factors.
entry is being
Yes.
a farmer.
Yes.
Could be.
I mean, even if you didn't go back to the farm, most of these people have mud houses and
Yes.
he was really living in the village. I doubt a transplant patient will go to work in the first month,
Yes.
especially
This
this
one.
guy with so much of
And
history.
another risk factor which I can see is like our hospital, a lot of construction was happening in our hospital. So that might be one of the, the reason.
But that is usually aspergillus
Yeah.
and
For blood culture is positive, this is one of the few fungi that grows in blood culture.
No, blood cultures was negative. It's only the tissue. And we were also concerned about the duration, because there's not much of a, what you call optimal duration of therapy, clarity on the optimal duration of therapy, particularly when we can't, assess with respect to tissue when we have got the amputation, and then, to correlate with the microbiological clearance of the tissue or the blood or the specimen. So how long to give the treatment? What would you call as optimal duration of therapy?
As long as it takes, and minimum of 6 weeks at this point. But this is osteomyelitis. If you had not done the amputation, you'd have put him on prolonged therapy. Here, because you removed the affected part, your life became easy.
Yeah.
Otherwise, you would have been you would have to keep him on lifelong therapy, especially because it's immunosuppressed. The question comes up about secondary prophylaxis even at this stage, which probably is not as concerning, because again, you amputated way above the infected area. And if you do have to give immunosuppression again, then that's something that you'll have to think through whether to give secondary prophylaxis.
Yeah, actually, that was my other concern. So, second time when we did a debridement of the, the stump, there was some necrosis. That was negative for the fungus, and whether should we go with a secondary prophylaxis, and whether each institute have their own protocols. So, in fact, we had an initial protocol of giving antifungal prophylaxis for all our post-transplant patients for 3 months. Recently, we have stopped giving that because it was very difficult to adjust the TAC levels, and we have seen a lot of infections. So, because of toxicity and then subsequent complications. So recently, we have stopped that. So, do you recommend the fungal prophylaxis immediate post-transplant, and when does it decreases the serious or invasive fungal infections, or it other way around, it causes more resistant fungal infections?
I think post-renal transplant, if you go by the guidelines, you don't really need antifungal prophylaxis.
Exactly.
Most of the time, we give fluconazole primarily to decrease the cost of tacrolimus, not for antifungal reasons. And you would not, even if you had given fluconazole, you wouldn't prevent things like fusarium. And these are not that frequent enough that you would routinely do put people on antifungal prophylaxis.
I think we'll
You're running out of time, I think.
Yeah, it's already.
I wanted to make a couple of comments. One is fusarium is one invasive mold where we don't know till we have the susceptibility. It is always better to use both amphotericin, either liposomal or conventional, or azole, that is voriconazole, or it could be posa, or or isava now. But I think vori is the drug of choice because fusarium has very varied susceptibility. It could be resistant to amphotericin or it could be resistant to vori. So whenever you have a fusarium, it is always better to use a combination therapy always. So that's the first guideline about fusarium. Second about is I wanted to check is very important is voriconazole. You always have to do a therapeutic drug monitoring because there is always possibility that the patient may be having a CYP genotype and then you may not be able to achieve the voriconazole level at all. The reason is we cannot use liposomal or conventional amphotericin B for 3 to 6 months. Now there is a guideline which talks about Candida osteomyelitis. If there is in spite of surgical debridement, they say we treat for 6 months, Candida osteomyelitis. Here we are talking about Aspergillus osteomyelitis and undergone amputation. So I agree with Sunita that whether 6 weeks or 3 months would have been ideal. That is the second thing. And the third thing is worry. Unlike posaconazole or your isavuconazole, which has to be, or itraconazole, which has to be taken after food with a fatty meal, voriconazole has to be taken on an empty stomach. So there is a difference between the azoles. Vori always has to be taken on empty stomach at least 30 minutes before the meal. Whereas the posa, itra, isava always to be taken after meals with a fatty meal. And I think therapeutic drug monitoring is the most important when using voriconazole for a long-term use. I think these were the.
How often do you need to monitor the drug levels? And is it available?
Yeah,
Cost?
the first therapeutic drug monitoring should be done ideally seven days after the voriconazole has been taken, and normally it is to be the blood level is 30 minutes before the morning dose or evening whatever the morning dose of the voriconazole level. So in Mumbai we are for I don't know about other cities, but I think it's available in many of these metropolis labs which are nationally available. So there it is available. So I think whether you use Vori, POSA or ITRA, it is very important that you do a therapeutic drug monitoring in your clinical practice. So that's very, very, very important. Otherwise, there'll be, I have seen a lot of failures because of not achieving the voriconazole level because of the CYP415, some enzyme genotype, which causes the, hydrolysis of this voriconazole. So this is what we have to. And also, I think another point which I want to make is that oral voriconazole is equivalent to IV voriconazole because oral voriconazole, the bioavailability is 90% to that of same like fluconazole. And the blood and the bone levels of voriconazole is so high that if you use voriconazole for 6 months, you might, some people may land up with fluoride toxicity, in the bone. So that is called as fluorosis, what we have. So the bone levels are extremely high with voriconazole. But excellent case, Prasanna and Dr. Swarnalata, for this is a very, very interesting case and very, very well handled, and the patient's life has been saved. So these are few comments which I wanted to make.
Sorry, can I ask
in
a
terms
quick
of-
question? Sorry.
Yeah.
Dr. Sunita or Dr. Vasant, is it common to have progression of osteomyelitis so quickly, like within a week? He started off with mild pain and then he lost the limb.
6 months of using Vori, you develop you asking about
The
The rapidity
infection
of-
part of it, the progression, the initial osteomyelitis.
Progression.
normally we don't see Aspergillus or Fusarium. Fusarium is slightly more progressive compared to Aspergillus because Fusarium, as Dr. Sunita said, it is also bloodstream, whereas Aspergillus is never seen in the blood. So Fusarium is slightly more malignant and more fulminant compared to your Aspergillus. So that is possible.
Thank you.
Dr. Abraham, your question about where you can get this tested, for you in Tamil Nadu, Newburgh, I think is the closest place that you can send it to. They are located at Bangalore. Newburgh does voriconazole levels, and CMC Vellore does voriconazole levels, all of the azole levels. But yeah, Anand Newburgh or Newburgh is closest for you.
Thank you.
So that was an extensive discussion. So before we close the session on the current case, there is a quick question in the chat box from Dr. Kajari Giri. Why was immunosuppression again restarted on discharge when patient was doing well without it with good graft function and urine output? And any guidelines when to restart immunosuppression after fungal infection? So any of the chairpersons?
No, I think that is, a $1 million question when to restart. It all depends upon the clinical situation and what possibility of salvaging the, the graft versus, increased risk of, the spreading the infection and as well as the losing the patient. So there are no specific guidelines. I think it's all experience and it was individually depending upon the condition of the patient. I think you can move on to the next case, Aarti. It's already been, 5 minutes.
I would like to invite Dr. Nath. He's a senior resident in nephrology at MIMS Hospital, Hyderabad, for his second case presentation.
My slides visible?
Not
No,
yet.
the slides are not visible, Nath.
Are they visible now?
Sure. Yeah, now it's visible now. Please carry on.
Thank you. Good evening, respected faculty. My name is Dr. A.S. Nath, and I'm here to present a case on early fungal pneumonia.
Echoing. Your voice is echoing.
Do you have one more device logged in via Zoom?
You're not audible. You're not audible, Nath, now.
Please unmute yourself.
Am I audible now, ma'am?
Yeah.
Yes.
So our patient is a 55-year-old male.
I think it's echoing, Nath. Your two devices are open. One of the device you can put your speaker off.
Yes.
Am I audible?
Yeah.
So our patient
is a 55-year-old male.
55-year-old male, politician by occupation, who was suffering from diabetes since 2011, renal dysfunction and hypertension since 2019. He was presumed to have a diabetic kidney disease. There was no native kidney disease that was done, biopsy which was done. He was on medical management between 2019 and 2022. And due to worsening creatinine, he was initiated on HT in 2022.
Nath, it is echoing. Amma, you can just move little away and then speak. When you're coming closer, it's echoing.
Ma'am, now am I audible now?
Yeah, you're audible, but every time you're audible, it's echoing.
Just a second, ma'am. Sorry for the...
Yes, use the same setting, no? Prasanna has used, no? Use the same setting.
Yes, ma'am.
Go little away from the speaker. When you're away, it's not echoing. When you're coming closer, it's echoing.
Now is it okay, ma'am?
Better.
Yes, ma'am. So all the entire course of his native kidney disease was at an outside hospital, and he came to NIMS. I am very sorry. I will just set the time, please. Is it echoing now, ma'am?
It's better. You can continue the presentation, doctor.
Yes. So the entire course of his illness was at an outside hospital, and he came to NIMS directly for kidney transplantation with spouse as a potential donor. So briefly speaking about his dialysis history, he was on dialysis since January 2022, and he never had a permanent access because he had primary failures of both sides, RC, radiocephalic and brachiocephalic fistulas. He had his non-tunneled IJVs changed thrice and 2 episodes of CRBSI as well. And he had a native output of less than 400 ml, no usual intradialytic complications. And he had not received any blood transfusions. His viral markers were negative, and he was appropriately vaccinated against hepatitis B and COVID. So on the inset, I've just shared the screenshot of one of the review articles that had come in 2021 March in the well-reputed journal Nature, which reviewed the current progress of vaccines against human fungal diseases, where a lot of challenges are still there and a lot of trials are going on, but we are still a long way from having real vaccines. So there are candidate vaccines against Candida, Aspergillus, Mucor, and all other fungi. So this patient was further worked up with his wife as donor. It was an ABO compatible donation. The wife was AB positive and the patient himself was O positive. The HLA typing showed a 4/6 mismatch. The CDC cross-match was negative. The DS donor-specific antibodies by flow cytometry method was negative. And the donor's age, his wife, was 49 years. She was a well-controlled hypertensive on amlodipine 5 milligram. And the GFR of her left kidney was 42 ml per minute. And he was appropriately worked up with endoscopy, and being a diabetic, 55 years, we underwent a coronary angiogram, which was normal. Pulmonary function test was normal. And then we proceeded to the transplant. He was transplanted on 2nd July 2022. And going into the transplant, he had a subclavian triple lumen H3 cath in situ. His IJV were thrombosed bilaterally. And he received an induction with ATG 50 milligram and methylprednisolone 3 gram on 3 consecutive days. And he also received standard triple immunosuppression, the dose being 20 milligram of prednisolone, cumulative dose of 6.5 milligram tacrolimus, and 2 gram of MMF. His tag genotyping showed that he was a poor metabolizer. And in the initial 10 days, there were 3 dose adjustments for high CNI trough levels. Talking about the graft, he had a slow graft function. And though he did not have obvious features of a bacteremia, the procalcitonin was elevated, and therefore we had given him a broad spectrum meropenem as empirical cover. He received it throughout his stay in the kidney transplant unit, and rest of the investigations were within normal limits. So here we have to realize that the net state of immunosuppression of our patient was pretty high to begin with, being a diabetic, with a past history of significant infections, having received induction from a biologically unrelated donor. And this is a screenshot of the serum creatinine trend from our hospital's app. So we can see that he had a very slow graft function, but he never required dialysis throughout his hospital stay. So by the time of discharge, we had achieved an added creatinine of around 1.48, as you can see on your screen. During his stay before discharge, he did have persistent cough in the first week, and a CT scan at that time had showed basal atelectasis and a mild right pleural effusion, very mild, not tappable. And he was managed with chest physiotherapy, incentive spirometry, and antitussive only, and he improved very well. He was discharged with POD 12 with a creatinine of 1.48. From POD 12 to POD 40, it was very uneven full, but for gastritis and on and off loose stools, for which the mycophenolate mofetil was changed to an entry-coated form. And we achieved during that period up to POD 40 an added creatinine of 1.34 as well. On the 10th of August, he reported to the hospital with very mild fever and cough. His COVID RT-PCR was positive, and he was advised home quarantine. And the government kit, which consisted of azithromycin and multivitamins, were given as treatment. He improved, and we had not modified immunosuppression at that point in time. It was a very mild disease. But however, around 1 week later, that is on 16th August, on POD 48, we had to admit him for worsening cough, increase in creatinine 2.33. Even the repeat RT-PCR at that time, 1 week later, was positive. And fearing a superadded bacterial infection, he did receive a course of amoxicillin clavulanate. And the HRCT at this point in time showed subpleural GGOs and a Corad CT severity score of 5 on 25, mild. But however, we did appreciate centrilobular nodules, predominantly in the right lower lobe. And due to infection control concerns, a BAL could not be done at that time because he was RT-PCR positive. And we also did a serum galactomannan at this point, which was negative. So here I would like to show the picture of the CT scan, where we are able to see the GGOs in the subpleural location in the lower lobe bilaterally. But also we can appreciate the centrilobular nodules, where you can see the pointer, dispersed throughout the bilateral lung fields, predominantly in the right lower lobe. So this was a cause of concern. And being a diabetic patient who had received a biologically unrelated transplant with ATG as induction, we were always wary about a fungal infection possibility. There's another picture showing the same thing. So the COVID per se was not very severe, very mild GGOs, only towards the lower zones. And the investigations during that admission showed a mild anemia, a mild leukocytosis. The creatinine was 2.33. We had an albumin of 3.4. These are the abnormal values I've highlighted. and the trough level was a little high at 11.2, and appropriate dose adjustment was done. The CMV PCR also we had done, which was negative. So during that admission, the continuation of his COVID illness, we had given an antibiotic cover for superadded illness, nebulizations and symptomatic management was given. His immunosuppression was modified. Mainly, we had halved the dose of antimetabolite mycophenolate sodium. He was taking 2 tablets twice daily. We made it 1 tablet twice daily. And tacrolimus was reduced by 0.5 milligram. He had no oxygen requirement throughout the hospital stay. And his sugars were also well controlled with his regular medication, which was a glycoside of 60 milligram. There was no insulin requirement. We were very keen to do a BAL for this patient because we wanted to rule out a fungal infection because of the presence of central lobular nodules, which are a harbinger of infections which may exacerbate in the later period. And he was readmitted after 10 days because he did have fever spikes and he did have persistent cough. After an initial period of afebrile illness, he again developed fever spikes. And this time the RT-PCR for SARS COVID virus was negative. So we did a repeat HRCT and a BAL was planned. So you can see how the CT worsened considerably over the next 10 days. And you can see that in the lower zones, in the posterior segment of both the lower lobes, we can see the consolidation that has developed surrounded by GGOs. This can be seen both in COVID as well as fungal infections. The typical halo sign that we see of consolidation surrounded by GGOs, which are appreciated where the pointer is there. Another picture to appreciate the same. So we had to decide whether we wanted to give antifungals, and he underwent a BAL, the reports of which I have presented on the screen. So he had a total white cell count of 180 cells in the bronchoalveolar lavage with 70% neutrophils. The gram stain showed no organisms. The KOH mount with chalcophore white staining showed no fungal elements. And the aerobic, anaerobic, as well as fungal culture sensitivity is no growth. We have to note here that aspergillus are usually fast growers. The gene export on the bile fluid was also negative. And the only, unfortunately, we did not have an aspergillus PCR, and the patient was not affordable for an outside multi-PCR respiratory panel. And the only positive value that we have had was a galactomannan, which was 1.4. You can see the screenshot on the backside of the screen as well. So we had a value of 1.4, which we took as very significant. And we made a presumptive diagnosis of aspergillosis at this point and started our patient on oral voriconazole with a concomitant 25% reduction of tacrolimus and 50% reduction in mycophenolate, which he already had. And he did not require oxygen in this admission also, but there was a drop in saturation. However, he was always maintaining a room air sat of more than 94%. In the same admission, we also made it a point to investigate his loose stools. EMV disease was ruled out, stool testing was negative for pathogens, and we had done an upper GI scopy which showed mild antral erosions. And due to the non-resolving creatinine, we also went ahead with an allograft biopsy, which showed only a mild acute tubular necrosis and no evidence of rejection. The current status of the patient, he's doing very well symptom-wise. He's afebrile totally. His cough has reduced by more than 95%, and he's in his 4th week of voriconazole at a dose of 200 milligram twice daily. And we've been doing well with TAC also now. I've showed the TAC levels, how erratically it was up and down during the initial part of post-transplant period. And luckily, even after the introduction of voriconazole at this point, where you can see the yellow arrow, we've been able to maintain his trough levels in target. And his creatinine currently on 23rd of September is 1.55. A brief discussion, risk factors in our patient and why we had a high degree of suspicion, because he was renal transplant, he received ATG, he had a COVID illness. During the COVID pandemic, the incidence of post-COVID aspergillosis was very high, especially because in critical illness where a lot of pulse steroids were used, which was not the case in our patient, but he had a very high dose of steroid in the background of transplant. He was a diabetic patient, and he also received multiple courses of antibiotics, meropenem, amoxiclav, azithromycin. Whether that could have played a role was also in our mind. And galactomannan testing is what we have to resort to more often than not when we don't have a positive yield on culture. And we felt it helped us a lot in make a presumptive diagnosis. And whether to use a positive titer of 0.5 or 1 is a matter of discussion. But anyway, our patient had 1.4, so it was beyond doubt. And we always felt that combining assays would be a better strategy, where a BAL and a serum galactomannan and a BAL and a serum PCR, if positive, gave us a lot of corroborative evidence. So diagnosing invasive aspergillosis, the gold standard would obviously be a culture of the aspergillus species and a HPE proof of tissue invasion by the hyphae, which is often not possible. And we do have to rely on the biomarkers and PCR assays in serum and BAL specimens. And once everything adds up, I think we can treat our patient, where the clinical scenario, the imaging on CT scans and biomarkers, if they coincide, then we can go ahead and treat. So thank you for the opportunity. This was my case presentation.
Thank you, Dr. Nath, for the crisp presentation. Now the forum is open to the chairpersons for further discussion about this patient.
Did you say the donor was AB and the recipient was O?
No, I think it was by mistake. It was a compatible AB compatible. It was to AB.
Okay, sorry, I got stuck there.
Yeah, no.
It was ABO compatible, ma'am. Sorry for that typing. Yeah.
Actually, I was heading the COVID in my hospital, and we treated about 5,000 patients. Like CMV in COVID, we got a lot of secondary infections, not just the mucor. Mucor became famous, it was there everywhere. We had a couple of patients with aspergillus, but only patients who had previous tuberculosis or previous lung disease. So maybe for this guy, the risk factor was the transplant.
Yes, ma'am.
Yeah, I think this was another challenging case, because he had come with almost immediate post-transplant, the pulmonary infection. So initially we got it done because this was a time where the fourth wave of COVID was going on. So that's why we got these COVID testing and was positive. And my symptoms were mild. In fact, he had a prolonged viremia phase, but subsequently repeat RT-PCR was also positive. So, and then he had a progressive symptoms. So this is where we went stuck, whether it's a COVID or whether it's a secondary infection, so bacterial infection or the fungal infection. And we didn't have any other evidence. And then, our pulmonologists were not very keen for doing, bronchoscopy. So this is the challenge we have faced. And subsequently, we have tried to manage with only the antibacterial, so considering it as again secondary bacterial infection. And the other decision making was whether to go for antivirals, particular remdesivir, because repeat RT-PCR is also positive. And subsequently, when patient's RT-PCR was negative, we went ahead with the BAL. And in BAL, there was no fungal elements, cultures were negative, and whether to treat the ASM as a fungal infection with only galactomannan positive. So these were the challenges. So
you didn't reduce immunosuppression when the COVID became positive?
Initially, because symptoms were very mild, we didn't reduce, and it was almost within a few weeks of the transplantation. So we continued with the same immunosuppression, but after a week, when the symptoms were worsening, and the repeat CT scan also showed the worsening of the the infiltrates. We then started reducing the MMF. Subsequently, we reduced even the attack as well.
So ICMR is sponsoring a few mycology labs around the country. I think 5 or 6. NIMS is going to be one of that, as well as St. John's, Bangalore. So in the south, these two are going to be there.
Our microbiologist, Dr. Uma Bala, is working
on it. So that will be an added advantage for the southern states to use the facilities to do, as they develop, to do all the aspergillus PCR, as you were mentioning, or beta-D-glucan, all of those things will be rolled in, as well as drug sensitivities for a lot of the filamentous fungi can potentially be done once these labs come in and they establish. Here, the diagnosis at best is like a possible aspergillosis, because we only have galactomannan. It's not the classic finding on the CT, and you don't have the bug as well. And even if you did see aspergillus in the BAL or in the sputum, that still will not tell you if it's invasive aspergillosis, because aspergillus can be a colonizer. So that's something that we have to keep in mind, unless it's consistent with the clinical picture. So, yeah, I had something else to say. Lost it.
I think I had a point to
So-
make. And I think your beta D glucan, I think it's not available easily everywhere. Beta D glucan, BDG.
NIMS is not doing beta D glucan at this time.
Sunita was saying. So I think that is an added, biomarker with galactomannan, because I have a very similar case to what Nath has presented. I'll be presenting a same case, very, very similar, anecdotal, but a different therapy used for clearing the COVID. So I'll be presenting that.
Yeah, the other point I wanted to mention was voriconazole typically affects your TAC levels. TAC levels go very high. I'm surprised it did not go high. So I'm actually wondering, did he absorb the voriconazole level and did he get therapeutic drug levels? Because since most of these patients anyway get TAC levels done, you can use the TAC level as a surrogate marker to see if your VORI levels are adequate or not. If your VORI levels go high, TAC levels automatically go high.
Yeah, by the time we have started, I think we have reduced our TAC levels almost to, I can say, 75%.
Okay,
So
then it's consistent. Then it's consistent.
Adjustments were done more than once, ma'am.
Okay.
And, as you have told, yes, ma'am. All our patients, including the first case that my colleague has presented, we did face very high TAC levels of up to 60 in the first case when we did start voriconazole.
Yeah.
I think it did go up to 22 or 24, and then I think with reduction it came down to 8.
Sometimes we switch to either posaconazole or isavuconazole just for managing the drug-drug interactions.
yeah, true. In fact, not this patient, the other patient we have managed with the isavuconazole, because his drug levels were very high. It was in the range of like 50 and 40. So despite reducing CNIs, it not come in. We could not come down on the TAC levels. So we have to change it to isavuconazole.
There's a question here by Dr. Arun Dua. What is the take of ID expert on galactomannan for diagnosing aspergillosis? How frequent are false positives and what caveats should we keep in mind? Like we just talked about it, galactomannan by itself does not tell you it's aspergillosis. It's at best comes to possible here. We do see what is the cutoff value that we are looking at. Different studies talk about it differently. Depends on, first of all, is it serum or BAL? And what is the clinical reason why we are doing it? Ideally, when you looked at the studies as such, you're talking about monitoring galactomannan serially and you see for a rise in titer. Here, we are not doing that. But when we are when we're sending off galactomannan, obviously, I would like to think that we have a high pretext probability, and because and when you see a positive galactomannan in the setting of a high pretest possibility, your positive predictive value probably will go up. Cutoff, various authors talk about it differently, but in general, we're thinking about 0.7 for serum and 1 for BAL. But higher the number, the more likelihood it is likely to be positive. And there's a newer company that's making this machine that do galactomannan. I failed to get the name of that machine. So that I think is giving a little bit more false positives. I have to check, monitor in my center. In my center, we've changed the machine we use for galactomannan, and we're seeing much higher galactomannan, like 4, 8, very high numbers. So just when you're seeing abnormally high numbers, maybe you need to look at what's happening. False positives are fairly common. Some antimicrobials can cause false positivity. Your dialysate can cause false positives. Lot of other fungal infections, including histoplasma and a bunch of others, can have false positives. So yeah, and Yeah. Any other points? Vasant, do you want to add anything more?
Actually, in my case, I'm going to speak lots on galactomancy.
Okay. I think, shall we move on then?
Yes, we
We're
can.
already behind time.
Thank you, chairpersons, for the wonderful discussion. Now, moving on to the next session of today's webinar, I would like to invite the chairpersons, Dr. Sunita Naredi and Dr. Shruti Tapwala. I think it's a bit late for the introduction part. Ma'am has already been in the webinar for nearly half an hour now. She's an AB certified MD in internal medicine and MD in infectious diseases. She is currently working as a senior consultant infectious diseases at Apollo Hospital, Hyderabad. She started the Department of ID at Apollo Hospital and subsequently the ID Fellowship. She is also part of the expert panel involving H1N1 pandemics, COVID pandemics, and she is also part of the WHO guideline developing group for drug-resistant TB. She is the founding member of Clinical Infectious Diseases Society India, and with this is such an illustrious CV, yes, we will be looking forward to her take on the fungal infection part. Now, moving on to the next chairperson, Dr. Shruti Tapiwala is a nephrologist at Mumbai. She did her fellowship in adult nephrology at University of Toronto and completed her multi-organ transplant fellowship. She also did her AST fellowship in HLA medicine and advanced transplant diagnostics. She is currently working as a senior consultant nephrologist and transplant physician at Global Hospital, Mumbai. Her areas of expertise include ABO incompatible transplants, high immunological risk transplants, and transplant immunology. She is also the Joint Secretary of the Win India Council and the Secretary of the ISN West Zone chapter. Now, I would like to invite Dr. Sunita Naredi to introduce the speaker of the next session, Dr. Vasant Nagwekar.
Do you have an intro slide? If you want to just go ahead and put it.
Yes.
Yeah.
Siddharth, can you project the intro slide?
So, Dr. Vasant is a very good friend and colleague of mine, and Dr. Vasant has trained in infectious disease in Apollo, Chennai. He is currently working in Lilavati, Mumbai. Works a lot in immunocompromised hosts and excellent teacher, and helps the state government in a lot of their issues, including COVID. So over to Vasant.
Thanks, Sunita, and thanks for the Win Transplant Committee for giving me this opportunity. Am I audible or?
Can we increase the volume of the microphone, sir, if possible?
I think,
Move close to the screen and you're okay.
yeah. Right. So fungi, I think just an introductory 4 or 5 slides. Fungi are ubiquitous microorganisms with a profound influence on agriculture and human and animal life. The worldwide, on an annual scale, at least 11.5 million deaths are attributed to cases of life-threatening invasive fungal disease. This is in general. I'm not talking about only in solid organ transplants. This exceeds death from malaria and tuberculosis. Invasive fungal diseases now cause 10% of all nosocomial infections with high mortality rates, almost 40 to 100%, despite the modern therapies. So if you see which fungal infection, which patient will get it, it depends upon what is the host behind getting the invasive fungal infections. If you see it's a medical or surgical ICU, it will be invariably candidiasis. If it's HIV, it's going to be cryptococcuses. If it's or PCP, if it's going to be solid organ transplant, then I think the initial part is going to be candida, followed by aspergillus, and after 6 months it could be crypto or any fusarium like the case presented. So there are a lot of controversies in the management of invasive mold infections. First is the diagnostic workup. What is the best diagnostic approach for invasive mold infections presenting with pulmonary nodules, BAL, or is it CT carried FNEC, or is the VATS, just like the case not presented? And it's always a possible or probable. For a best diagnostics, always a gold standard is always histopathological diagnosis. Second is, what is the role of PCR in the diagnosis of invasive mold infections? What is the role of combining PCR with galactomannan as a diagnostic approach for invasive mold infections, especially aspergillosis? What is the role of CT angiography in the diagnosis of invasive mold infections? So I think all these are controversial issues, or they have yes and no answer. And when it comes to management, what is the role of in vitro susceptibility testing for mold isolates in guiding the management of invasive mold infections? I think I have one slide on this which talks about in vitro susceptibility for molds. Candida, I think all of us know, but what about molds? What is the role of adding an echinocandin in the preemptive treatment of triazole and amphotericin B associated invasive mold infections? What is the optimal timing of de-escalation after the onset of preemptive treatment of invasive mold infections, like the first case which was presented? What is the optimal antifungal management in patients with invasive mold infections and baseline or antifungal drug-induced liver or renal dysfunction? What is the role of adjunct immunotherapy in the management of IMIs? What is the role of surgical debulking or isolated pulmonary lesions? I think the foot lesion was easy to ampute, but when it comes to pulmonary lesions, debulking is a major concern here. What is the optimal timing of resuming chemotherapy? A critical element, like in the first case, what would be the timing of resuming the immunosuppression for that patient? Like the question was asked, is all these are controversial or difficult questions to answer, and it is all clinical, it is case by case based. If you see the timeline of invasive fungal infections in the renal transplant, it is 103 days for candidiasis, 184 days for roughly for aspergillosis, around close to a year for zygomycosis, but this can vary from case to case, but this is overall a rough estimate what is there. Around cryptococcus, not seen before 1 year, it is always seen normally whatever crypto I've seen, which is also very common invasive fungal disease seen in renal transplant, usually seen after a period of 1 year. I think if you see this slide, less than 1 month, you always see Candida, and Candida. Rarely you'll have aspergillosis. 1 to 6 months you'll have, because patients are usually on bacterium prophylaxis, so PCP is less likely. You'll always see aspergillus or cryptococcosis. When it comes to more than 6 months, it would be usually aspergillosis, it could be cryptococcosis, or it could be PCP, because by then majority of the patients are of bacterium prophylaxis. So why solid organ transplants are prone for invasive fungal infections? So after transplant, the extent of immune response is influenced by the amount of interleukin 2 being produced by the T helper cells. And we are using many of the patients do use anti-interleukin 2 drugs, and that is known to be prone for invasive fungal diseases. Currently, overall mortality due to invasive fungal infections in solid organ transplants range between 25 to 80%, and a majority of them is Candida in the first month. So most fungal infections occur in the first 6 months, but later on we do see cryptococcosis, aspergillus, fusarium, and mucormycosis what we see. So we see that in US also we have more than 15,000 renal transplants are performed with a 5-year survival rate of 80%, and the rate of infection in renal transplant patients during the initial 3 years after transplant is 46%, and is associated with duration and the net dose of immunosuppressive agents given. I'm working with a lot of liver transplants and to a certain extent with kidney transplant, but what I'm seeing is maximum whatever invasive diseases, because the immunosuppression is quite intense with renal transplant compared to the liver transplant, because we use a lot of basiliximab, or we use anti-thymocyte globulin or high dose of steroid, which is not much used in liver transplant. Liver transplant, we see more of Candida and rarely Aspergillus. So liver transplant patients are already severely immunocompromised by the time they are transplanted. So risk factors for transplant recipient, different risk factors between early and late diseases is development of renal failure will be risk factors for invasive aspergillosis post transplant requiring hemodialysis, and late invasive aspergillosis would be chronic impaired graft function or requiring graft dysfunction, requiring again an anti-thymocyte globulin or receiving high dose solimidol. All this would be contributing to the risk for invasive aspergillosis. I'll come to the first case, a 54 years male, ABI incompatibility, 11 months down the line, he had received rituximab, anti-thymocyte globulin presently on MMF tacrolimus, receives, he develops a COVID on 10th of July 22, receives 3 days of remdesivir. His afebrile, his HRCT chest done that time was normal. Again, he developed fever after 10 days of getting better. Again, he's tested COVID positive. That is nothing new that, patients keep turning positive, but he was symptomatic and he started developing breathlessness with the CT scan score going up to 10 by 25, which initially the CT was normal. He reserves, the physician gives him a methylpred as because he thinks that this patient most likely has gone in the inflammatory stage, that is stage 2B of COVID, with a fever persistent. His nucleocapsid antibodies were negative. That means he has not mounted a immune response to the COVID. He's admitted at Lilavati subsequently with mild hypoxia. He receives, for a change, this is an anecdotal case where we do not have the specific Omicron antibody with us. So this, what we were using, I think all of us have been using, is 600 and 600 milligram of casirivimab, indivimab. Here, there was a trial which was going on about using higher dose, that is almost 4.8 grams of casirivimab plus indivimab. And we did use, because the only way here I thought using 600 and 600 wouldn't help him to get negative, because the present problem, what was going on, was ongoing COVID. And I think the only way to get him better was to get rid of this COVID. And I think I took a chance and went and gave a very high dose of cocktail antibody with remdesivir. He was afebrile after 48 hours, and his COVID test was negative after 7 days. Again, we did test his antibodies were negative. Again, he started with fever on 22nd September. That means almost after a period of 1.5 months. He was COVID negative this time. His nucleocapsid antibodies were positive. That means he had mounted a response. His CT scan during the discharge time, or we did in between, were much better. His this time the new onset fever was because of influenza A, and he was treated with oseltamivir. Unfortunately, his low-grade fever persisted, and if you see this 22nd September 2022, the reports which is showing influenza A positive and the COVID negative, and this you can see the CT scan films of 22nd July, which shows that he is having that peripheral GGOs, which were typical of COVID specific. And you'll see the 22nd of September, the CT scan which was done, which shows complete clearing of the COVID pneumonia which was there, and they're coming up with a new lesion in the left base. I mean, we cannot say this is the old COVID, because you can see completely new lesion with clearing of all the more lesions and persistence. So what we did is we sent some biomarkers for this patient, and you can see this lesion. Now, what is this lesion? Is it aspergillosis? Is it mucormycosis? Is it cryptococcosis? Is it fusarium? So it's very difficult to identify what it could be. So what we could do here at this stage is rely upon, one is to do a BAL bronchoscopy and do a BAL, but the patient refused for a BAL. He was a doctor himself, so he refused for a BAL. And otherwise, how would a BAL would have helped me is possibly getting a aspergillus culture, which could have been still a probable aspergillosis, as Sunita said. Culture don't say it's a gold standard. Second is BAL galactomannan would have helped me. Third is getting a BAL PCR PCP. Whether are we dealing with PCP? But PCPs will never have peripheral lesions. They are always peripheral sparing. PCP is always peripheral sparing. So we did send a beta-D-glucan and we sent a galactomannan here. And another thing is, what you can do is to rule out cryptococoma is you can send a cryptococcal antigen, serum cryptococcal antigen, which will be 95% sensitive, I would say, and also specific if it is negative or even if it is positive. So anyway, for mucor and fusarium, you can't do anything. But if your biomarkers, galactomannan and beta-D-glucan, are negative, then possibly that might tell you that possibly you're not dealing with PCP, or you're not dealing with aspergillosis, and possibly you're dealing with maybe nocardia, maybe bacterial, maybe fusarium, maybe mucormycosis, or maybe cryptococcosis. So I think another thing what we can do is to look at a fundus examination. I think fundus, sometimes you can see a small cryptococoma in the fundus, and that might. So I think another very, very important a clinical marker in bedside is to ask for a fundus examination, which do tell you a lot of things about. Sometimes it might tell you CMV, it might tell you tuberculosis. This could be TB also. So it can might show you tubercle, or it might show you a cryptococcoma in the eye, small crypto. So I think a fundus examination is something which we should not forget in our clinical practice when we are stuck with the diagnosis of a patient. So I think this was the case, and you can see that 22nd, it's almost complete, nicely clearing, and whereas on 22nd 9, it's showing a nice these lesions coming up along with persistence of fever, clearing of COVID, falling, making COVID antibodies, and still galactomannan. So the aspergillus galactomannan came as 1.2, but there's a huge question mark. What should be the cutoff? Should it be 0.5? Should it be 1? Should it be 1.5? Should it be 2? Or should it be 3? So we don't know what exactly is the cutoff. But his beta D glucan came as more than 523.43. So it's very sky high. But whenever I see such a beta D glucan of more than 523, it always strikes me of PCP, because such a high beta D glucan we always see with PCP. But here, I think the peripheral, nicely nodular lesion with a halo is more likely to be possibly aspergillus, because beta D glucan goes high in 3 invasive fungal diseases. One is Candida, second is aspergillosis, and third is PCP. Rarely you might get fungal, beta D glucan positive in histoplasmosis. But beta D glucan negative here would have prompted me, if I have to think about fungal infections, then it would have been 2 fungal infections which have a sure shot negative beta D glucan, is Cryptococcus and mucormycosis. I think this would definitely tell me that I'm not dealing with PCP or aspergillosis. But here, I think getting the scenario, it was more likely to be aspergillosis, and PCP. That is what. So another thing was we could have done is, another thing is gold standard is to do a CT guided biopsy of this lesion. So that was another option where we would have achieved a gold standard of demonstrating that is the gold standard. So about aspergillosis. So here this patient was treated as probable aspergillosis, and if you see this fungitel 1,3 beta D glucan assay, it is got a more than positive. I think specifically positivity is more for your PCP, but it has got a much more negative predictivity value. It has got a negative predictivity value for Candida aspergillus. In fact, if it's negative, it helps you to rule out aspergillus and Candida, and it can be used as a very useful tool, biomarker, as an antifungal stewardship when you're using a lot of echinocandins in your patients for treating Candida. If your beta D glucan is negative, that tells you possibly you are not dealing with Candida. So it's it's a very useful test, but I know that it's not freely available in many of the cities. I'm fortunate in Mumbai, we have it in Chennai. I know that Apollo Chennai is doing it. I don't know about Hyderabad, but I think many of these bigger tertiary care centers do 1,3 beta D glucan. And though the test is slightly expensive, but one echinocandin costs you 15,000 rupees into 14 or 18 days will cost around 2 to 3 lakhs. One beta D glucan will just cost you 5,000, but it might help you to get your diagnosis positive and more, I would say, a negative predictivity value. But many times high bilirubin hemodialysis can interfere with your beta D glucan levels. Coming to galactomannan, I think I'll come to more details about what is the specificity and sensitivity of aspergillus. Like aspergillus also, the most common aspergillus in India is Aspergillus fumigatus, followed by flavus, and we do see Terrius and sometimes fumigatus, flavus, Terrius, and one more Aspergillus BC. So I think, as we said, construction is the most important site where the reason where Aspergillus is seen. And I think this was discussed in one of the slides when we say possible, probable, and definitive aspergillosis. Definitive aspergillosis is a histopathological diagnosis. Probable aspergillosis is host plus a biomarker plus plus a radiological feature. When we say possible, it is host plus either a biomarker or radiological. So when you have a host and a radiology and a biomarker, we say it's probable, and definitive is a histopathological diagnosis. So what should be the cutoff of galactomannan? I think if you see this slide, I'm sorry for this busy slide, but you see that the higher you see this 0.5, 1, 1.5, the lower the galactomannan you keep, you will get more and more positivity, because it is a more sensitive test. So the lower the level you keep, will come more positive. So I think the cutoff usually internationally, what they have said is 1 or 1.5 is the cutoff, because the higher the cutoff, your specificity will increase. If you see this from the first, second, and third, if you see the higher the cutoff, your specificity is more. The lower the cutoff, your sensitivity is more. So that is the difference between. So same thing, when you keep a cutoff of 0.5, you will have almost 8 out of 10 patients. You will say that these are aspergillosis. When you say it is your cutoff is 1.5, you will be subjecting less and less patients for further tests. Similarly, the same thing, the cutoff is not known, but I think what the EORCT criteria or other, they say is you should can count as 1 or 1.5. Now, coming to this case again, which had a peripheral lesion, another way of possibly could have, but since kidney transplant, so we can't use a CT pulmonary angio. I did mention in first slide that a CT pulmonary angio helps you to possibly diagnose a invasive fungal infection from a bacterial pneumonia, and that is because when you do a CT pulmonary angio, along the lesion you will see a cutoff in the vasculature. You'll see a complete cutoff there just before the lesion, because invasive fungal diseases, aspergillus or mucor, they are vaso-occlusive. So you will see a cutoff there. Whereas in bacterial pneumonia, you will see through and through the pulmonary arteries. And that is why your CT pulmonary angio sometimes may be helpful in diagnosing between a bacterial pneumonia and an invasive fungal consolidation. So if you see galactomannan, the sensitivity is around 70% and specificity is around 80%. Especially it is more sensitive in when your patient is neutropenic. Beta-D glucan again has got a much value for negative. It has got a much negative predictivity value than positive predictive value. If you combine PCR plus galactomannan, it has got a much higher sensitivity and specificity to the more than 90%, I think, which was discussed in the last case which Nath presented. So I think a combination of this would help you, or if a combination of a serum PCR plus beta-D glucan or a serum galactomannan or a beta-D glucan is a very good test which will help you to possibly say this could be a possible or probable aspergillosis. So I think a serum, this was a CAPA guideline, which I think the last case or even my case, which was presented, shows a galactomannan of more than 0.5 plus a BAL galactomannan plus a positive. So I think all these criteria should be fitted, and it is not really easy. I would say aspergillus is the most difficult fungal infection to diagnose, because the treatment is easy, but diagnosing aspergillus is always challenging. Mucor diagnosing is not difficult because you have only histopathological diagnosis. Candida is not difficult, or even fusarium. The most difficult is when you say probable aspergillosis, where 30 to 40% of the times you can be wrong. And the next slide, which tells you about is about what is the importance of having the susceptibility. Like Candida, you have a various susceptibility. So is the susceptibility very important to be seen in aspergillus? And if you can see this is a patient which I had, and of course this was a liver transplant patient, where the BAL, galactomannan culture, everything grew aspergillus flavors, because the bilirubin was very high and the creatinine was just borderline. But the bilirubin was some 20-30. We couldn't give azoles here. So for these flavors, we gave liposomal amphotericin B. The patient did not improve, neither deteriorated. The patient was just static. And the reason is, if you see the amphotericin B, amphotericin B breakpoint here is 2. The susceptible, it is showing susceptible, but when you go to this real criteria, if you say aspergillus flavors, the breakpoint is 2. So that means when you say 2, that means possibly your patient may or may not improve. I want to go again back to the slide saying that this susceptibility is very important when it comes to aspergillus flavors. Aspergillus fumigatus will be sensitive to liposomal amphotericin convention, because we always think that amphotericin is the broadest antifungal. But when it comes to aspergillus, it starts having hiccups, because Aspergillus flavus, Terriers, and your Terriers, Terriers and your Niger will have a higher MICs for amphotericin B. So amphotericin is not the best choice when it comes to Aspergillus. Azoles is A1, or a gold standard is A1, because you'll see this slide that amphotericin B, the susceptibility or MIC is 2. But what is the break point? Break point is also 2. So that means the patient may not improve. And the comments are that high MICs of more than 1 have been reported in Aspergillus Terriers. And when you have MICs more than 1, may be species dependent, and you can have when you have amphotericin B MICs more than 1, you can have a clinical failure like our patient had. And finally, we put the patient on isavuconazole, and the patient did very well. So this 2 slides I brought into the account was that susceptibility, if you can get the MICs and the susceptibility, it's very important, just like your candida, or to see whether your patient would definitely do well or not. So if you see the A1 PCIL guidelines also, A1 recommendation for aspergillosis is voriconazole and now isavuconazole. So for voriconazole, whenever you're using TAC, you normally require to reduce the dose by, I would say 70%, 60 to 70%. But when it comes to isavuconazole, it would be anywhere from 40 to 50% of the dose you will have to reduce it. So when it comes to amphotericin, it's a B1 recommendation when it comes to treatment of invasive aspergillosis. So amphotericin is not the best drug when it comes to treatment of invasive aspergillosis. It is always azoles, and the reason is flavus, Terriers, and Niger. Your patients may fail if your amphotericin B MICs are more than 1, and I think that is what we have to keep in mind. Coming to the next case, it's a 26 years male for 14 months post kidney transplant, admitted with fever, 10 days, cough, respiratory distress, TMPX is stopped. He is on MMF, sirolimus, prednisolone, X-ray chest, and CT scan. So you can see that these are peripheral sparing in the CT scan, unlike the previous CT scan, which was having peripheral shadow. So this is peripheral sparing. And so here is a differential diagnosis. The patient's hemoglobin is 9.6. Counts were on the lower side, 3,500. LFTs were normal. Respiratory biofire was sent. His LDH was 276. So differentials were, is it PCP? Is it cytomegalovirus? Is it sirolimus induced acute lung injury? Because sirolimus is very well known to cause inflammatory syndrome, and we had one patient where it typically looks like a PCP hypoxia. We had to ventilate that patient. Or is it any of these respiratory viruses which are circulating in the community? Or is it a fungal infection, any apart from PCP? So what next? Should we do a BAL? Should we do a BAL plus biopsy here? Should we do an open lung biopsy, or go with the present parameters? So this patient was tachypnic, and so doing a BAL is really challenging sometimes in these patients. So normally patients with PCP will always be tachypnic, and doing a BAL means possibly they may get ventilated. Open lung biopsy is really difficult sometimes. Of course, that would be the best, but that is not possible. So if you're doing a BAL, there is a test which is available for PCP, and that is called as PCR PCP, and it is also available in many of the labs. I'm lucky to have it in my hospital, but I think if you have it, you can send it to your tertiary care centers or tertiary lab centers, where you can get a PCR for PCP, which is another very, very important fungal biomarker, which will help you to diagnose PCP. So this patient's sputum was negative for PCP. CMV viral load was 3768, not very impressive, but there is no correlation of serum viral load with a CMV pneumonitis, what we see. So CMV viral load was biofire was biofire. The respiratory for viruses was negative. The PCP sputum, which is a very poor test to do, PCP sputum was negative. LDH was borderline high, but not a very specific or sensitive test. So any other test which will help you to diagnose PCP in this radiological setting of a diffuse GGO, and you'll see that the beta D glucan of this patient was more than 523. So there are 2 tests which will help you to diagnose this PCP. One is beta D glucan. If your beta D glucan is negative here, it helps you to rule out PCP. If it is sky high, as I said, normally PCP, you'll always get a very high value of beta D glucan. Another test is to do a BAL. If you're doing a BAL, you can do, of course, you can do a PCP stains, or immunofluorescence stain. But another test, which, because those are subjective sometimes, but PCR PCP is a very objective test which can help you to diagnose PCP. So 1,3 beta D glucan, I think I already spoken about that, has got a much greater negative predictivity value than positive predictivity. I think GGO post transplant on TM, not on TMP prophylaxis, 1,3 beta D glucan is a very useful test for high suspicion, has a high negative predictivity value, which will rule out PCP for sure in this GGO. Aspergillosis, Candida never causes lung lesion. Candida is a normal flora of the respiratory tract. It will never cause a lung lesion. Now, coming to this next case, this is a very interesting case. We recently had it at HN Reliance. This is a, I don't know, do I have 5 minutes or 10 minutes to go ahead? Chairpersons?
I think go ahead, Vasant.
Please go ahead.
Okay. So this is a very interesting case. I'll slightly go slow here. 33 years, female, hypertension, CKD. She underwent a renal transplant, 2020 live donor. Initially, post-transplant had CMV viremia and then had recurrent episode of UTI in the past year. Was on MMF plus tacrolimus plus Visolon. Baseline creatinine was 1.7. She was admitted on 25th of May 2022 with fever for 5 days and vomiting. CBC of 8, CBC showing slightly elevated counts, creatinine of 3, and urine culture showed Klebsiella 10⁵, and it was a ESBL. That means it was a sensitive bug. So I think for all, we were comfortable saying that this could be most likely ESBL, Klebsiella pyelonephritis, and she was treated with piperacillin tazobactam. And what happened, the viral load also came as 13,750. This was the previous admission I'm talking about. Given Valganciclovir 450 milligram OD because of the creatinine and discharged on 35/22. So we were not into the picture this time. On discharge, the creatinine was 2.65. Readmitted on 14 June, fever for 5 days, sharp inspiratory right-sided chest pain and breathlessness, requiring 3 liters of O2 to maintain saturations. Hemoglobin was 6. She had leukopenia. Creatinine was 3.92. So the neutrophil count, I think, was some 700 only. Absolute neutrophil count, what I'm talking about. The CRP was 120. She had tachycardia and chest. She had a decreased air entry on the right side of the chest and mild tenderness on the transplant kidney side. So this was the X-ray where she showed that right basal. And I think I'll try to play this video where you can see this. So I think she had a bilateral pneumonia in this patient. And so the CT chest also showed patchy nodular consolidation, mitral lobe, and left lower lobe with mediastinal enlarges, measuring some, there was a lymph node which was 3.1 centimeter. But she was slightly tachypneic. So thoughts were, is it CMV disease or is it a HCAP in an immunocompromised individual who's getting repeatedly admitted? So is it some MDRO, organism which is causing? Or is it any opportunistic infection like aspergillus? Okay, so these were the thoughts which came to our mind. With acute history of chest pain, breathlessness, and high fever, patient was put empirically on meropenem plus a gram-positive coverage, which is covers MRSA well. She was coming from the community, and in view of pancytopenia, MMF, valganciclovir was stopped. The next day, patient chest pain did disappear for, she got better. Breathlessness was better for some reason, unknown reason why she got better, we do not know, because the history continues. The creatinine was 3.16, the respiratory biofire and the sputum culture all were negative. Day 4 of the illness, patient had mild giddiness, the pulse rate was 110, she had mild tenderness on the transplant kidney site. Day 5, patient was transferred to the ICU in view of progressive breathlessness. The beta D glucan was 94. So that tells me that we are not dealing with PCP, we are not dealing with aspergillosis. So the parvovirus was negative. BK virus serum urine was negative, serum plus urine, and the repeat serum viral load was also negative. So this was the progression of the pneumonia with bilateral effusion compared to before, and the bulky right kidney with fat standing. So what happened was finally the blood culture came as growing east. So any guesses what it could be? So after all this, the blood culture came as yeast, and the urine culture also showed yeast.
Candida auris.
Yes, that's what we thought so. But a very important biomarker, beta D glucan being close to negative. So cutoff is around 60 to 80. It is 92. So that tells me that possibly we may not be dealing with Aspergillus candida or PCP here. And what it grew Cryptococcus neoformans. So the urine as well as blood grew Cryptococcus neoformans. So this was, and we couldn't do a BAL, but BAL and in a LP was not possible because she got altered. So patient was diagnosed as disseminated cryptococcosis with cryptococcal pyelonephritis. I think this is something I'm showing you cases, but what I wanted to show you is that when I talk about invasive fungal infection, how it will be bedside or in your clinical, how it would help you to diagnose. So this beta D glucan galactomannan, which is commonly used, is very important. So this beta D glucan was negative, and when you have a yeast in the blood, especially in a HIV or a renal transplant patient who is moving around in the wards or is quite stable, Candida will mean a patient would have collapsed. So meaning it is, always think about other yeast, like, it could be Cryptococcus or Geotrichum or Trichosporon. So appropriate management, whether we use conventional or liposomal, we have to know that our liposomal amphotericin B will cost 50,000 rupees per day year for this patient, but will not. So here is, we have two things in mind. One is to treat the pneumonia, and second is to treat the pyelonephritis and also the urinary system, which is having that cryptococcus. Now, which are the best drugs which will come in the urinary system apart from kidney? So the best drugs which will come in the bladder, in the ureter, are only three drugs. One is flucon. Sorry. Second is 5-flucytosine, which is, we have forgotten that drug. And the third is our poor conventional liposomal amphotericin B. So your 50,000 liposomal, 50,000 rupees liposomal amphotericin B is very good for as far as the renal parenchyma, renal parenchyma, but it has got very poor concentration in the urine, so it does not help in renal pyelonephritis with renal urethritis or in the renal cystitis. So the drug which will be helpful would be conventional amphotericin B. But here what we did was we used liposomal amphotericin B for the renal parenchyma because the creatinine was high, and we used high dose fluconazole for the 6 milligram, 12 milligram initially and 6 milligram, because fluconazole has got 20 times the level in the serum to come in the urine. So we use this combination for this patient. Unfortunately, this patient did not do well because finally the kidney was so bad. We wanted to do a nephrectomy, which was justified, but in this patient, but the relatives refused and took LAMA. So cryptococcal in a transplanted kidney, recurrent urine tract infection is one of the, I think, one differential which we should keep in mind. I already spoken about liposomal ampho B or conventional ampho B, and role of 5-flucytosine, which we should use it in conjunction with, because that is the drug of choice to clear into the renal, very high levels in the urinary system. So I think immunosuppression should definitely be stopped. Here the patient's life was more important and not the kidney. So that is what was important. I think this was an interesting case, and I think I'll go to this case, which is another which I wanted to point out about what Shruti said about Candida auris. So this was a patient with 61 years male. So the learning from the previous case was every UTI repeatedly. Please think also when you have yeast cryptococcosis, you can do a serum cryptococcal antigen. If you have beta D glucan negative, it will help you to diagnose cryptococcosis. So cryptococcus is very, very common in renal transplant patients. Hardly we see in liver transplant patients, or hardly we see in heart transplant patients, which we are seeing so much of heart. We do a lot of heart transplants there in HN, but we don't see so much of crypto. It is more seen in renal transplant patients or maybe lung transplants. So this is 61 years male, hypertension 15 years, diabetic 15 years, CABG 2009, CKD 2007, transplanted 2014, right toe imputation on 2018. He was admitted with a penile ulcer with a pneumonia. He had a Morganella, and his penile lesion was growing Candida auris. He got better, and then again there was a new onset sepsis, hypotension, and his blood culture grew, candida, and that candida was candida auris. So I think we have moved away from, in India, the most common non-candida, in the Western world, it is always albicans, whereas in India, it is always non-albicans. And among the non-albicans, the most common is Candida tropicalis, which forms around 50% of the non-albicans. 15% is formed by parapsilosis, 15 by your glabrata, and 10% by your cruzi. And now, around, I would say, initially the Dr. Arunal's paper did say 6% of the cases are auris. I'm saying that auris has overtaken even your cruzi and glabrata, and we are seeing more and more Candida auris. So what is the specialty about Candida auris? Candida auris is just like a MDR Klebsiella or MDR E. coli or MDR Pseudomonas. It is a multi-drug resistant Candida, very difficult to eradicate. It is close to 90% or 95% resistant to fluconazole. It is close to 80, in India, at least 70 to 80% resistant to your amphotericin, that is polines. The only susceptible drug is echinocandins. And in your renal transplant patients, echinocandins have very, very poor penetration in the urinary system. And the only echinocandin which has fairly around 4% penetration in the urinary system, or what you would see levels, is micafungin. So sometimes you can use 100 to 150 milligram of micafungin as a treatment for Candida auris, because Candida auris is a notorious with a very, very high mortality having among, because it's really difficult. It is not only difficult to treat but difficult to eradicate, because the infection control practices for Candida auris is same like your C. diff. It gets stuck to your railings, bed sheets, your doors, your monitors. You name anything inside the room, it gets colonized with Candida auris. So it's very important. Candida auris means you have to wear its strict contact precautions with a gowning and gloving is very, very important in all your renal transplant patients, whether they colonized or whether they are infected. Candida auris has to be treated as an emergency, otherwise it spreads like a fire in the other patients in the ICU. So I think I'll skip this case. This was a very interesting case which I've seen in Apollo. This is one case which again I want to say, 23 years, post-kidney transplant, fever, cough, no weight loss. And you'll see multiple nodules in the lung, post-kidney transplant, just 1 month. And, bile galactomannan was 2.32. Cultures were negative. AFB stains, cultures were negative. TB gene export was negative. So is this a probable aspergillosis? Host, radiology, and a biomarker? How good it is. Sometimes this patient was put on voriconazole, but patient was not doing well. The fever continued, the cough continued. And if you see that the sensitivity for a respiratory samples is very poor, BAL is fairly better. In one of the journals of clinical in oncology, which said that BAL galactomannan more than 3 is 100% specific. So I think in my clinical practice, I use a BAL galactomannan of more than 3. If it is 2 or 2.5 and 1.5, I'm not very impressed. So what I do is I use a beta D glucan additional marker along with this BAL. If the BAL galactomannan is 2.32, I usually get a beta D glucan. So that helps. That combination helps me to possibly come more closer, not definitive, but closer to the diagnosis of aspergillosis. So in my practice, I use this paper and I use BAL galactomannan of more than 3 as the cutoff for my patients when I'm using it. So BAL or a biopsy. So BAL we already did. So we finally, the patient was not improving and we decided to go ahead with a CT guided biopsy. And what did the CT guided biopsy show? Granulomatous disease positive for mycobacterial tuberculosis. So that means follow-ups can after 2 months of AKT is that. So lesson learned is don't completely rely on biomarkers and serology. They are just support to our clinical diagnosis, but we cannot completely rely and close our eyes. Gold standard for aspergillosis is histopath. And here you can see that it was not aspergillosis, but it was tuberculosis. So I think I would stop here because almost 9 o'clock. Otherwise, I have got more cases. I think Shruti, I'll stop here and I would take more questions to take.
Thank you very much, Dr. Vasan, for that exhaustive presentation.
One slide I want to show. This was the case of mucor. I just want to show one slide, if you don't mind. This slide is very, very important. So whenever you suspecting mucor, and the most common mucor is rhino-orbital sinus mucor. Okay, the first thing is whenever you suspect, you catch hold of a ENT surgeon, tell him to do a scrapings in the night, doesn't matter, or in the morning at the earliest. And the fastest test for mucor is to get a calcoflower stain. Calcoflower stain is the fastest one to diagnose at least suspect mucor. So the most important is catch hold of a surgeon to get you the scraping. Second is start the treatment as early as possible. Third, so there are four principles, I would say five principles in when you're treating mucor. One is catch hold of the diagnosis is very important. Start antifungal therapy, very, very important. Catch hold of the surgeon. If it's proven mucor, you have to debulk, that is surgically operate. Improvement in the immunosuppressions, which is very, very important. And so these are four important principles. One is early diagnosis, early treatment, early surgery, improvement in the metabolic factors. And fifth is that most important, which I think Shruti and all of us have learned during the COVID times, is it cannot be one person or two person. It has to be a team of 5 or 6 people. That is one ID physician, one nephrologist, one ENT surgeon, one physician who looks after the metabolic parameters, and one radiology department. So it's a teamwork when you're treating a mucormycosis. Single-handedly, when you treat, you'll always land up with failures. Thanks for your kind attention.
Thank you, sir. I would now like to invite the chairpersons for further discussion.
I think that was a wonderful talk, a very very good discussion with all the aspects of fungal infections which we deal with in our clinical practice, and all the cases which have highlighted how we should analyze these cases. I'm sure the students have also enjoyed a lot. So let me throw the floor open to questions from the attendees, and then we can take this ahead. Dr. Sunita, anything?
Very, very good talk. Thank you, Vasant. And yeah, any questions from anybody?
Currently, there are no questions in the chat box. So, the chairpersons have anything to add on? Then we will.
I think it is very correct for Dr. Nagvekar to say that, we have to work as a team, because, everyone will put forth their facet and the jigsaw puzzle has to be set across. So for the students and for everyone who's attending, when we are dealing with transplant patients, immunosuppression, immune stratification, we want to see that we do not cause rejection to the patient. Because see, treating an infection is as important as protecting the kidney against infection. So we have to always balance these factors, is what I would like to stress. All the antifungals which are being suggested also have to be adjusted based on your immunosuppression. Tacrolimus levels especially have to be monitored, very important. So I think we all have to scientifically analyze every infection which we come across, whether it is a CMV, whether it's a viral infection, a malignancy, or a bacterial infection in a transplant patient, because these are all exotic stuff which can literally kill our patient. Like we saw in all the cases today, there was a very dismal outcome in most of the patients which we saw. And the most important part for students to learn is do not over immunosuppress patients. Do not, especially when there is COVID, try to reduce the immunosuppression. You may not stop it, make it half and carry it on, because these are infections which are making you more immunocompromised and more susceptible for you to get patients infected.
Yeah, Shruti, this is Dr. Manjusha. Can I ask a question to Dr. Vasant?
Yes,
yeah,
sure.
We have been seeing in pneumocystis carini, but we have also heard of pneumocystis girovici, whatever it is called. Is it common in Indian scenario? How does it differ? What is the difference in outcome between PJP and PCP, sir?
PCP.
So it's more or less the same terminology, girovici, and that's what we call it.
Manjusha, recently we have also seen a lot of PCPs in our cohort. I don't know, we have had a spurt of PCPs in the last 1 year. In fact, we presented a series of 8 PCP infections presenting as hypercalcemia and masquerading with hypercalcemia causing AKI, and then for us to realize that the lung has PCP. So even we have been seeing a lot of PCP nowadays. I'm not sure why the spurt. Dr. Nagwekar, any thoughts why we have? I don't know, because we were wondering if there is any correlation with the other infections which are happening.
I know. I think I do not know whether it's something to do with COVID, because COVID has been an immunosuppressive disease. And the only difference, if you see if you were not seeing 2 years back and now, is the COVID. So there is some amount of immunosuppression definitely there, which is proning the patient for aspergillosis and all this. Like the first case I showed, no? So a typical.
Dr. Vasan, one question from me again. What is the best and cost-effective test that you will suggest for a suspected aspergillosis? Of course, you have spoken so much about that, but in a constrained situation where all the lab facilities are not available, the suspicion remains high. Then what is the best and probably cost-effective also?
So I think your patient is clinically stable, and the best I think would be a CT guided biopsy for the lesion, because that will 100% prove you or disprove you about whether this is aspergillosis or not aspergillosis. So I think the gold standard, I would go for that gold standard test, because otherwise all these are expensive and you're still not very confident about.
Yes.
Not very confident. So I think the patient is not breathless and stable, I would go for a CT guided biopsy for that test, because even then you'll do a bile galectamen and aspergillus, and as we seen that case 2.32, and finally the biopsy was the answer. So I would say if you have a lesion, try to get it, because I think it may not be aspergillus, it may be something else. But I think the test, if you ask me, most cost effective and easier and definitive would be a histopathological diagnosis.
Yeah, excellent talk, Dr. Vasant. Like you have covered all the aspects of fungal infection. So I think fungal infection, though it's the incidence is less in post-transplant, around 1 to 5%, but the outcomes are very bad. You end up losing patients in 80% of the patient, either the graft or the patient. So, and I think most important aspect is high index of suspicious, the early diagnosis, and then appropriate management of with antifungals, management of the immunosuppressant medications. So clinically, I mean, as you have discussed, and we have also pointed out that basically we don't end up in having the evidence what you said is possible or plausible the infections. So when do we start these antifungal as an empirical therapy? And we have tried antibacterial. Sometimes we end up giving a cocktail like antibacterial, the tuberculosis treatment, and then antifungals also. So when can we start this as an empirical therapy? I mean, are we right in using these medications? So particularly post-transplant situations.
So I would try to go as close to the diagnosis, because I would be hesitant to start antifungal, because once you start your antifungals, the problem is when would you wait for the response for that patient? It is 2 weeks or is it 4 weeks? We don't know. So I would say, Swarnalata, I would be comfortable in trying to diagnose it as much as possible. I would spend some money in that rather than trying empirical and then patient deteriorating and then losing. So I would be more comfortable in, and I think Sunita will believe that from ID point of view, we always diagnosis is very, very important for us.
Do you have any of the biomarkers specific for each of the fungal infections? Like, something like one the galectamen, and we have this aspergillus, as you said, highlighted about the what is called beta D glucan for so and so infection. Something like each fungal infection, each biomarker.
So for PCP, it is beta D glucan. For crypto and mucor, beta D glucan negativity helps. Okay. Then for candida, again, beta D glucan negativity helps. Positivity also helps. And for aspergillus, it is galactaminin when I would say more than 1.5 or something. Again, beta D glucan is a useful biomarker for even aspergillus. So in fact, we have been dealing, apart from transplant and kidney, I'm seeing so much of paraspinal infections, and patients getting operated, putting cages, and one year not being diagnosed, and finally, and it's sometimes, I'm telling you, aspergillus is very difficult, and these biomarkers like beta D glucan did help us to diagnose, like beta D glucan of 450 and all that. and then we use single agent therapy, that is Vori, for that these patients, and they have done fabulously well. So I think aspergillus is, I would say, the most challenging and difficult fungal infection to diagnose, though it was easy and easy to treat and easy everything away, but it's most challenging, I think, among all the fungal infections.
Thank you, sir.
So thank you very much, dear chairpersons and the presenters, and a special thanks to Dr. Vasant, our guest speaker for today's session, for your time and efforts. The hard work behind the presentation was very evident. And I would like to thank the WIN committee and Dr. Swarnalata ma'am for having me to host the webinar session today. Hope everyone had a enlightening discussion. So we will wind up today session now. We are having the next WIN webinar tomorrow at 7 o'clock Indian Standard Time. It will be on cardio-renal conditions. So we have got few interesting talks lined up on that as well. So hope to see you all tomorrow at 7 o'clock.
Thanks for the opportunity, and thanks Shruti and everybody, and thanks bye Sunita.
We enjoyed the session. Thank you.
Thank you. Thank you.
Thank you, Dr. Vasant and team.
In fact, this is a series of transplant programs. So we'll come up with the interesting topics, the next session. So looking forward for. If you want any interesting topic, please convey to us. We will host that series on that topic. Thank you. Thank you, everyone.